Great. Well, thank you so much, Richard. Before I get started, I just want to get something out of the way since I'm talking about the Massachusetts health reform law. So Mitt Romney, Mitt Romney, Mitt Romney, Mitt Romney, Mitt Romney, Mitt Romney. So I just want to, that's just an important preface to any Massachusetts healthcare reform talks. Actually, Richard mentioned PolitiFact. Today on the PolitiFact, politifact.com, it's like one of the 2 or 3 like fact-checked websites. They have a quiz. Can you tell the difference between Obamacare and Romney Care? And I took it this morning. I got 10 out of 10 right. But if you really want to be a health wonk, go to their site today, and you can take the quiz. I'm here to talk as a visitor from the future, basically. Hopefully from your future. So Massachusetts passed its health reform in 2006. So we've had 5 years of implementation experience. And there's been ups and downs. And before I get into the meat, I just want to say one of the key lessons of implementation that we've learned again and again is it's not a one-time event. It's an ongoing, continuous process. And in New York, as you do your implementation of the ACA, it's really important to not just pass your exchange law, which is important, and say we've done it, but there has to be what we call continuous policy improvement. So there's a feedback loop, just the way auto manufacturers have built in. So along the way, you're going to make adjustment after adjustment and change after change. And that's not bad, that's good. That's the way good policy is made. But anyway, we've had 5 years of implementation experience. And where we are today is we have over 98% of the people in the state have health insurance. Our employers, more of them are offering health coverage than before, considerably more, despite the recession, which hit our state pretty hard like everywhere else. We have improvements, real improvements in overall health. We've seen reductions in smoking, increases in preventive services. The percent of people who say they avoid care because of cost is down considerably. And there's widespread public support. And I think the most telling fact is, with all the politicization of the individual mandate and how this is the death of freedom and the end of the American way and all of that, and we have conservatives in Massachusetts. Remember, we've had Republican governors for 16 years. We have they're small, but they exist in Massachusetts. In our state legislature, there's not been one single bill introduced to repeal our health care law. I mean, not even a bill introduced. You would think if the individual mandate and state-regulated exchanges and all the rest are the death of freedom, that somebody would just drop a bill in, but we haven't even had one. So I think that sort of tells you the political atmosphere in Massachusetts. So what I want to focus on is sort of public health insurance coverage and what Massachusetts can teach New York in terms of public coverage. And I guess I would start, there's a joke, I don't know if it's Jon Stewart or Jerry Seinfeld. One of them says, I'm not a Jew, I'm Jewish, right? And I'm allowed to say that. My wife's a rabbi, so I'm allowed to say that. So we don't have a public option in Massachusetts, but we have a public-ish option. Okay? So that's where we are. And you can do the same thing in New York, and I'm going to explain at the end how you can do it. It's one of the options under the ACA. So the state set up a program that's called Commonwealth Care. And Commonwealth Care is subsidized private insurance for low-income people with sliding scale subsidies. Right? Sound familiar to all of you working on the issue? So sliding scale subsidies now in Massachusetts, it's only for adults. Under the ACA, it's for families. And the way the Commonwealth Care works, it's offered by the exchange, which is called the connector. And the connector in Massachusetts was set up as a state authority. We love state authorities in Massachusetts. They're hybrids. They're kind of half government, half private. The authority, the connector, is governed by a board with 10 members. 4 of the members are state officials, and 6 of the members are private citizens. And they hold open public meetings. I go to all of the connector board meetings. There's about 80 of us that are like connector groupies. We go to all the meetings. And what's so interesting is that the private citizens on the board worked so hard and put in amazing efforts to get this right and to work on it. They meet roughly monthly. In the beginning, they were meeting twice a month. They have subcommittees and so on. By the way, it's really important. The 6 private citizens, 3 of them have policy expertise, and 3 of them are kind of interest group representatives. The 3 policy experts are an economist, an actuary, and a benefits expert. And then the 3 interest groups represented are labor, business, and consumers. Notice that there's nobody representing hospitals, there's no one representing insurers, no one representing physicians. And we think that's been part of their success, by the way, is avoiding the kind of conflict of interest that you would get if you had somebody with direct financial interest. Because if you had a hospital interest on the board or an insurer interest on the board, I think you'd get different results. And the connectors worked very hard to come up with consensus solutions. They, I think almost every key vote was worked out to be either a 9-1 or a 10-0 vote. They've had no tie votes, they've had no close votes. Because of this give and take. And there were big disagreements, but they found Anyway, the Connector Authority administers Commonwealth care, and this is why I say it's public-ish. So the plans that are offered through Commonwealth care, and there's 5 of them, they are private health insurance plans. They're not government plans per se. But the state authority, the Connector Authority, really tells them what they do and how they do it so that they serve the public interest. So, for example, the Connector sets the benefits for Commonwealth care. There's a standard benefit package, and all the plans offer the same core benefits. There's some variations on one plan offers bike helmets and things like that to try to attract people, but the core medical benefits are the same under all the plans. So that makes it public-ish. The premiums are set by the Connector. They're on a sliding scale, like I said, and they vary by, they're on a progressive scale, so the lower income you are, the less of a percent of income you pay. They go from about free, no premiums at all if you're below 150% of poverty. Then they go from about 2.5% of poverty, 2.5% of your income to about 4 to about 6% of income. So as your income goes up between 0 and 300% of poverty, the percent of your income you pay in premiums goes up as well. So that's another reason why I would say that it's public-ish. The premiums are set by the Connector Authority. The co-pays are also on a sliding scale. And this is also something the ACA, I don't think we've paid enough attention to. There's also, in addition to the tax credits on the premiums, there's also cost-sharing subsidies that low-income people will also be able to get. And those mirror what we have in Commonwealth care. So low-income people pay $10 for an office visit and maybe $20 for a month's supply of a brand-name drug. And that goes up to maybe, I think, $15 for an office visit and $40, I think, for a brand-name drug a month's supply. And there are other co-pays for emergency room use and other things. So the co-pays are also set by the Connector Authority. The Connector sets the standards for participation to make sure that the plans have enough doctors in their network, enough hospitals, there are standards. There has to be at least one hospital within so many miles of every enrollee. There has to be at least so many primary care doctors within a certain distance for every enrollee. They also set customer service standards on what kinds of customer service requirements the plans have to meet. Their website and marketing strategies to prevent kind of marketing scams have to be pre-approved by the Connector. So again, these are private plans, but there's a lot of government oversight. And I guess the most important thing, particularly for people in state government worried about budgets and costs, is the Connector sets up a bidding strategy to make sure the plans provide good value. They use a lot of different strategies to incent the plans to provide low bids. And among those are auto-assignment of members, so low bidding plans get the auto-assignments of members who don't pick a plan. They also use a risk-sharing arrangements so that if any plan were to attract higher risks, there's an adjustment so the risk is shared equally among all the plans. And then there's also a stop loss for the plan. So if a plan bids too low and is worried they're going to take a bath, the state actually will step in and pay some of their losses if there's a loss. Also, the state collects all the premiums. So when the members in Commonwealth care pay their premiums, they don't pay them to the plan, they pay them to the state. And that way the state can get the advantages of scale, having one premium collection entity and one system for people that are late on paying, and then they remit the premiums to the plans. And then the last thing is that the state decides the eligibility. So there's one eligibility form for Commonwealth Care and for Medicaid and for all the others. There's a bunch of other smaller state health programs. So people don't have to apply just for Commonwealth Care. They can apply for other programs. So here's the bottom line for the state budget. In the 4 years that they've been in existence, the annual rate increases in Commonwealth Care have been 5.1% on average. And this year they're negotiating for year 5, and it's going to be under 5% as well. So while regular insurance has been increasing at double-digit rates, using this public-ish plan, they've been able to hold rate increases down to below 5%, less than half the prevailing rate. And then my last thing is, how can we do this in New York? How can you do this in New York? And the answer is something that has a horrible name. It's called the Basic Health Plan option. And it really shouldn't be called Basic Health Plan because it's going to be a comprehensive health plan. But the Basic Health Plan allows states to take 95% of what they would get in the subsidies for low-income families in the exchange, and instead of putting people at the mercy of the exchange, let the state offer plans along the lines of Commonwealth Care. And I think that's something that you in New York needs to think real hard about. We think it makes a lot of sense. We're certainly going to be doing that in Massachusetts, converting our Commonwealth Care Plan into the Basic Health Plan starting in 2014. And I think this is a way to get maybe the best of both worlds. In areas where the public option is politically not feasible, or there's a need for choice and private plans, and that certainly was the case in Massachusetts, going to the Basic Health Plan option and mirroring the sort of public-ish approach to Commonwealth Care might be a good answer for New York. So thanks.